Now come to this class of ectopic pregnancy. You know some long questions are given in the theory exam. So this is a long question. This is a long question. The question will be, the questions are some problem questions and structured problem. So it's not the defined ectopic. Some women at this age came to you with some pain, bleeding and amenorrhea, and on examination, patient is in shock. So how to diagnose the case and what are the differential diagnosis and how you are going to manage it. This is a structured question. So you have to write properly. And not only that ectopic, we will show some slides, I will show some slides that maybe come to the OSCE. OSCE, even the picture of operations, what operation is that, or it may come in the ATCOM also, ATCOM. So ATCOM you know one portion, the ectopic is also there, ATCOM. So counseling of the mother following successful operation of ectopic pregnancy. So how will you counsel? So that is a question of ATCOM. So we will stress upon the, while discussing this, stress upon all these things. Types, pathology, presentation, investigation and diagnosis, differential diagnosis, that we will discuss in detail, and treatment. So how to separate one diagnosis from the another. So then is the treatment. So many conditions may appear like ectopic, and they will be presented as bleeding in early months of pregnancy. Bleeding in early months of pregnancy, among them is abortion, ectopic and H-mole. These are the three important conditions. Then come to, so this is the picture, so that can be given in OSCE. What is the type of ectopic pregnancy? Tubal. Tubal may be so many, maybe isthmic, maybe interstitial, maybe ampullary, so many. So this is likely the portion it is shown is isthmus, not in the ampulla. So isthmus, and near the cornu will be interstitial. Interstitial, and ovary, if it is there, then will be ovarian, or within the cervix it may be cervical. So that picture may be given in the OSCE for the diagnosis. So definition, you know, outside the body of the uterine cavity, maybe in the cervix, maybe in the at the cornu, that means interstitial. There is difference. You may not be asked that fine differences, but that is there, not outside the body. So that is the normal site of implantation. So types tubal is 95%, and ovarian, cervical, cornual are 1, 2, 3 like this persons. So last addition is the scar pregnancy, CS scar pregnancy. Pregnancy over the scar, though it is at the lower part of the body of the uterus, but because it is over the scar, so it is regarded as ectopic pregnancy. Not only that, its management and presentation, everything on scar pregnancy is like ectopic pregnancy. So that is the scar pregnancy. And then you come, you see the percentage are given there. This will not be asked. Among these is just to note that ampullary is 75%. Ampullary is 75%. This is the thing, and this portion which we are talking at the cornu, actually this is within the interstitial portion of the tube. Otherwise it is not ectopic. If it is lateral to that, towards the endometrial cavity, it will not behave like ectopic. It will gradually go towards the uterine cavity, so it will be intrauterine pregnancy. But if it is within the interstitial portion of the tube, because this portion of the tube, interstitial portion, have a thick musculature, thick muscle wall, so it will not easily rupture. The longest portion it will run of the ectopic pregnancy is among the tubal interstitial portion. So come to the next slide. So pathology, you know, because of the absence of submucous layer on the tube, so decidua is not formed. decidua is not formed, no decidua. So because of lacking of decidua, conceptus don't get the nutrition, so conceptus will die. That will lead to tubal mole. That may come as a short note. What do you mean by tubal mole? And then these conceptus may be extruded, it is implanted there. So at the fimbrial end or at the ampulla, by the tubal peristalsis, it may be expelled. So that will cause tubal abortion. So in that case, bleeding will not be that much. So tubal abortion, and then extrusion through the tubal mole is tubal abortion, or rupture, because the muscular wall of the tube is thin. After some time, tube is distended and it will lead to rupture. Not only that, because of the lack of the submucous layer, the trophoblast will invade the muscle easily, leading to rupture. So lack of space and invading the muscle, tubal muscle, so that is the rupture. And either by abortion or by rupture, if incidentally that conceptus is live, so that will be implanted into the peritoneal cavity anywhere, we do not know, maybe on the vital organs, because the trophoblastic tissue has the unique power of invasion, so that will get the vascularity from the peritoneum or from the peritoneal viable structure. So that will be implanted in the peritoneal cavity, maybe even within the lips of the broad ligament. So that will cause the secondary abdominal pregnancy. That is also ectopic pregnancy. Possibly that is missed on that list. Secondary abdominal pregnancy, not the primary. So that is a ectopic pregnancy. And all these, you see, leads to abortion or rupture, will lead to intra-abdominal bleeding. So that is also a feature. So bleeding in the peritoneal cavity will lead to chemical peritonitis. So you get the features of peritonism. So that is one of the abdominal signs will be there with the ectopic pregnancy. So that will come in the diseases which produces abdominal signs will come in the differential diagnosis of ectopic pregnancy. You see, uterus, because of the estrogen progesterone, so initial enlargement of the uterus is not by the fetus, but by the estrogen progesterone, that is hypertrophy and hyperplasia. So uterus will be definitely enlarged, and endometrium will be much proliferated because of the estrogen, but there is no decidua, so that will lead to excessive proliferation, proliferative reaction, that is the area stellar reaction, that is basically adenomatous hyperplasia. But feature is, as there is no trophoblastic tissue in the endometrium, so there is no villi. So absence of villi in the endometrium or decidua, that is the feature of ectopic pregnancy. And so, and decidual cast. Decidual cast, this picture I have deliberately given because this may be given as a OSCE. What is the name of this picture? Whole of the endometrium, it just cut open. So if you fold it, it will be a circular uterine shape, triangular shaped structure. So whole of the endometrium as a whole has been slapped up. That is called decidual cast. So why there is ectopic pregnancy? So many risk factors is there, including the abnormalities of the tube, that means excessively long tube, because the basic mechanism of ectopic pregnancy, the transportation through the tube is arrested. If it is a long tube, it will be arrested before it reaches the peritoneal cavity, uterine cavity, or if the tubal motility is hampered, it will be arrested, or if the ciliary function is lost, which causes the helps in fertilized ovum, transport of the fertilized ovum, or because of the peritubal adhesions, motility is impaired because of the peritoneal adhesion, or because of the peritubal adhesion due to infection, that means PID, or due to some operations, previous laparotomy, maybe following cesarean section, maybe cholecystectomy operation. So previous laparotomy is a risk factor for peritubal adhesion leading to impaired motility, the tubes leading to impaired transport of the fertilized ovum, leading to implantation, because implantation occurs by 6th or 7th days, but before that because trophoblast develops, so it can be implanted there by 6th day. So and most important factor, risk factor for ectopic is previous ectopic. Previous ectopic because usually the PID, so young female who usually suffers from the PID, that means that is a STD disease, sexually transmitted diseases, very young female just before marriage, leading to salpingitis, which is bilateral. So one tube you have removed because of ectopic, but because the pathology was bilateral, so on the other side risk of ectopic is there. So previous ectopic is very important factor. That is the point of ETCOM. So if the patient has come with ectopic, how will counsel the patient? So for the next pregnancy, so that is be given in the ectom. Presentation you all know may be acute, that means usually severe pallor, acute abdomen, severe pain abdomen and shock. So if the triad is there, amenorrhea, pain abdomen and bleeding and shock, so then there is no confusion. In a female, ectopic must be excluded first. So many conditions, we will come to DD, can give rise to the same problem like pain, bleeding and shock, intra-abdominal bleeding. Even the surgical situations also come, splenic rupture or something else. So, but that all are not ectopic. So that you have to exclude first, and so many patients we have seen to die because of the treating the patient in the medicine or surgery because of the pain, abdomen and anemia like that. So when it was referred to gynecology, it was so late that patient has developed multi-organ failure and death of the patient. So ectopic pregnancy is important because it still causes death of the mother, maternal death, one of the cause of maternal death. Then subacute usually not that acute picture, but maybe intrauterine, maybe extrauterine. So all are in a dilemma. So in that case, we have to take all measures to exclude ectopic, because if you miss the diagnosis, if you send the patient to the home, so next day she will come in a dead condition. In a such condition, you will not be able to resuscitate, or she will die on the way to come to the hospital. So that is very important. Subacute patient, we are always conscious, always remains concerned about that. That's why we say you have to be always ectopic minded. You have to diagnose ectopic, otherwise it will miss. Always somebody is coming with pain and always you try to exclude ectopic. If it is not, then it is okay. So since subacute, then it is unruptured. Unruptured when? Because of your concern, possibly you have done USG, early pregnancy, to see whether it is ectopic or whether you get any sac within the uterus or not. So if you don't get any sac within the uterus, then you are always concerned, possibly it may be ectopic. So again, second USG, if you don't find it, then it is a unruptured ectopic pregnancy, or you may be lucky enough to note the sac within the tube. So that is presentation. Unruptured, 3 types. So clinical picture I have already stated: acute pain abdomen, bleeding PV, amenorrhea, shock. About the pain abdomen, if this pain abdomen, patient feels pain abdomen and the shoulder, so that is the feature we have to note for ectopic pregnancy, because hemoperitoneum, when she is lying down, because blood is moving to the under surface of the diaphragm, so that is giving rise to the pain in the shoulder region. So bleeding per vagina, this is very important. You see, bleeding may not be much, slight bleeding but much pain. In abortion, there will be much bleeding, less pain, but in ectopic there is less bleeding but much pain, and shock will be more than the loss of blood. So, and then amenorrhea is very short. A patient may not be able to remember the menstrual period. So often on history, the amenorrhea will be missed. Amenorrhea will be missed because by the time before missing the period, already 15 days conceptus may be implanted in the tube, and that may give rise to some bleeding, so which can be mistaken as the bleeding of menstruation. But actually, because by 15 days is the time of bleeding of the next period, so that amenorrhea may be missed. So always ectopic minded, otherwise it will be missed. Shock, bleeding inside because of the intraperitoneal bleeding. Tenderness on examination, apart from shock, tenderness is plus. So you cannot miss this tenderness. Patient will not allow you to touch the abdomen. So tender. Distended abdomen will be there, abdominal distension, and PV, if you are lucky enough, if she allows to do PV, then adnexal tender mass, usually not in acute cases, POD, fullness, blood clot. So usually subacute cases on POD, pouch of Douglas, if you get full because of the blood clot, then possibly it favors the ectopic pregnancy. Subacute, see where the fetus patient is moving up and about, but patient is suffering from amenorrhea or delayed period. Patient may, that is better to call it delayed period, and irregular bleeding per vagina. So amenorrhea, which is interpreted as delayed period and followed by irregular bleeding, everybody will think that is possibly because of the menstrual problem. Actually, ectopic pregnancy may be presented like this, but pallor may be marked. So irregular bleeding PV is, in all the cases, we advise urine for pregnancy test to exclude ectopic pregnancy or pregnancy related bleeding. So PV adnexal mass will be there, and cervical motion tenderness. So on moving the cervix, because of the hemoperitoneum, patient will have much pain. So motion tenderness, this is called, and so pregnancy test must in all cases of irregular bleeding PV, that I have mentioned. So to exclude ectopic in subacute presentation, pregnancy test must be done. Unruptured, in cases of amenorrhea, when the patient is coming, you are going for transvaginal sonography, likely because of the risk factors are there, or because there is previous pregnancy, you are always concerned. So TVS can detect adnexal mass or the gestational sac within the tube. So examination usually do not give any clue. So all are okay, tenderness is not much, and mass is not there by PV. So abdominal examination is also no peritonism, but pregnancy test is positive. Pregnancy test is positive even if you don't find any mass, any sac in the TVS. Always up to that, a diagnosis will be pregnancy of unknown location. You do not know whether it is intrauterine or extrauterine. So that will be the pregnancy of unknown location until and unless it is diagnosed as a ectopic somewhere. So unruptured. Investigation, you all know, urine pregnancy test positive. Ultrasonography, uterus is negative. Uterus, no sac in the uterus. So that is the two basic points. USG negative, urine positive. Means likely it is ectopic pregnancy. So adnexal mass fetus may be found, and in the adnexal mass, because of the placental tissue, on Doppler USG you get very ring of fire, very red area of the vascularity around the gestational sac. That means that is a feature of ectopic pregnancy. Other masses will not give to this of such of vascularity, ring of fire like. So collection in POD, if you find then about 100 ml or more, then that is suggestive of ectopic pregnancy, because maybe because of abortion, or maybe because of subacute rupture. Serum beta-hCG is very important. Serum beta-hCG, you see, usually we get TVS. If the serum beta-hCG is more than 2000, you are supposed to get a gestational sac in the uterus. If you don't get gestational sac, that means you are possibly dealing with the ectopic pregnancy. That is important for serum, especially in cases of diagnostic dilemma or in cases of pregnancy of unknown location. Serum beta-hCG is very important, and if none of these things are available, gadgets are not there, so many advantages are not there, if you are suspecting the anemia with pain abdomen, so in that case, if you take the patient to the OT and puncture the pouch of Douglas, that is called callocentesis. Callocentesis, if blood has come, so that is usually that blood does not clot because of peritoneal blood, so that is the feature of a suspect ectopic. Previously, when we were student, there was no USG, beta-hCG was not available in the hospital, so we used to diagnose the ectopic by puncturing the pouch of Douglas. Investigation is, apart from that, laparoscopy. Laparoscopy nowadays is very important diagnostic tool about the intra-abdominal conditions. So similarly in gynecology also, on laparoscopy, where you have especially the diagnostic problem. So by laparoscopy, you can see whether there is a tube is healthy or not, and if there is hemoperitoneum and site of ectopic, everything you can see, provided the patient is hemodynamically stable. Because in ectopic pregnancy, you cannot make the patient hemodynamically stable by blood transfusion. Whatever blood you give, it will be collected in the peritoneum. So hemodynamically stable patient only you can go for laparoscopy. That is for diagnostic purposes as well as treatment. So when you see by laparoscopy the ectopic pregnancy, you can do the necessary treatment. Or if you don't see in ectopic pregnancy, it is other than that, suppose it is a ruptured corpus luteum cyst, that will give us to same feature, that will give us to bleeding also. So in that case, you don't do anything, you just come out. Or if you see that no such things are there, possibilities appendicitis, the large appendix, you can do appendicectomy and come out. So everything can be done by putting laparoscope. Only thing so, this is a very important tool for dealing with the ectopic. This is a laparoscopic view. So that hemoperitoneum is there, and you see at the fimbria, this is the distended part. So here is the ectopic. So this can be given for diagnosis. So ectopic pregnancy with hemoperitoneum. This is the uterus, you see. No, this is not the uterus. No, this is round ligament. The round ligament, not this coming here. Here is the, what is this? This is tube going to the, it's not clear, but this is tube that has been shown, and this is, so uterus will be this side, not the other side, and it is hemoperitoneum. Differential diagnosis, some of which I have already discussed about the differential diagnosis. So abortion is very important. So whether you are dealing with a abortion, tubal abortion, or it is a intrauterine pregnancy abortion. So the same feature will be there. Pain abdomen, pregnancy test is also positive. So the treatments are different. One is laparotomy and one is doing nothing. Abortion is just evacuation. So that is very important. Differentiating pictures are abdominal signs will not be present in cases of abortion. So clinically you must be competent enough to determine whether it is a intrauterine pregnancy abortion or it is a ectopic pregnancy like tubal abortion or ruptured tubal pregnancy. So absence of peritoneal signs, abortion, and hypotension and shock and pallor will be proportionate to the blood loss in abortion, but in case of ectopic it will be disproportionate. So acute PID, so pain abdomen will be there, and in this case lower abdominal pain of course, but in acute PID the fever will be there and pregnancy test will be negative. So that is important point. So pregnancy test negative, or if you are not assured, you can go for beta-hCG test from the blood. So if pregnancy test is negative, so this is not, it is acute PID, may not be but peritoneum, your tubal masses will be there in acute PID. So that is the area of confusion. And you see, around the mass there will not be any ring of fire, which I have mentioned on USD findings. Twisted ovarian cyst. So pallor will not be marked either in acute PID or on twisted ovarian cyst. Acute pain abdomen will be there, signs of peritoneism will be there, pregnancy test will be negative, and that pregnancy test will be negative. So that in cases of twisted ovarian cyst, that is important, very important. And so USD there will be tubal mass. So pallor will be absent. Or not be that marked. So in the twisted ovarian cyst or acute PID. So in that way, you can clinically will be able to distinguish whether it is ectopic or not. Then ruptured corpus luteal cyst, very close features like ectopic pregnancy. So intra-abdominal bleeding is there. Only thing that pregnancy test is negative. And ruptured corpus luteum cyst, other features will be there. So previously it would have been landed in laparotomy because of all these features, but nowadays by laparoscopy we can easily exclude it. And acute appendicitis, so that is very important, may appear as ectopic pregnancy if the bleeding is not much, only pain is there. So only thing, appendicitis is one-sided, but usually PID and ectopic are whole lower abdomen there will be pain, but appendicitis is only right-sided. So if this is right-sided ectopic, only in that case it may be confused. So these are the all points you have to mention on differential diagnosis. Then come to the treatment. Treatment is basically mostly surgical because of these acute features most of the time, and medical where acute features are not there, and there are certain criteria where medical treatment will be successful, and expectant where even medical treatment is not needed, just by observation the ectopic pregnancy will be gradually cleared up by the body. So these are the three modalities of treatment. In cases of laparotomy, because the patient is in shock, you should not take much time. Quick in and quick out. So always it will be midline incision. For quick entry, midline incision, because it will be less bleeding and most of the layers will be cut by through the linea alba. So midline incision and blood transfusion, blood should be made ready, and after clamping at the cornu, then we give the blood. So the operation, self-injectomy. Definite operation for ectopic is self-injectomy. So clamp should be put at the cornu. So when you put the clamp on the cornu, bleeding will be stopped, and other clamp will be put on the mesosalpinx other side. So in that way, after the loss of blood is stopped, you can go for blood transfusion. So salpingectomy means removal of the tube, and provided the other tube is healthy. If the other tube is also damaged, if you do salpingectomy, so then patient will not be able to conceive. That's why before going for salpingectomy, you have to examine the other tube. Salpingostomy, if I don't give the S, it will be salpingotomy. Salpingostomy, tube is preserved, but product removed, incision not closed. That's why ostomy. But In laparotomy, we close the incision, but when it is ostomy, we do not close the incision. So no suture is given. So the criteria is the sac diameter should be less than 2 centimeter ectopic mass, less than 2 centimeter by USD. So definitely it will be done. These are the hemodynamically stable cases, and milking of the tube for removal of the chorionic tissue. So there is risk of retention of the chorionic tissue later on. So that should be, the follow-up should be done in those cases. So let's see the picture. You see this may be given in the OSCE. So here you put the clamp and here you put the clamp. So on the lateral side, from the medial side, you see ovary is preserved. So this is mesosalpinx, this is mesosalpinx, and this is over the cornu. This is salpingectomy. Here is the ectopic. And this portion you see the resection of the tube, where other tube is not healthy, so you can go for resection and anastomosis. So this all can be done laparoscopically. So that is called partial salpingectomy. So many of us are expert enough to do all these things by laparoscopy. And this is salpingectomy, and this is what I have said, when the pregnancy is here, that means it is at the level of cornu. So interstitial portion of the tube is removed, because here the uterine artery ends here, this area, and ovarian artery anastomos here. So this area is very much vascular. So very important, very difficult to do this operation. So this is actually practically a cornual resection and repair of the uterine wall. So that is the cornual resection in case of interstitial tubal pregnancy. You see the clamp has been put there, and other here there is, instead of clamp, this portion of the uterus is cut and repaired, will be repaired. Here you see laparoscopically it is done. You see this is the portion of the tube, and you put incision there. Then you take the product out, and you keep this tube remain open. So that is salpingostomy. Salpingostomy. This picture is not clear. This is the diagrammatic schematic, though this is clear. And so medical management. So that is about the surgical management. So if it is hemodynamically not stable, especially surgical management is very important. Majority of the cases will presented in acute condition, so surgical management is the most important part. Then you come to the medical management. Now we are talking about the estimation of beta-hCG. It must be less than 5,000, because if this beta-hCG indicates chorionic activity. If it is more than that, the risk is rupture. So you are giving methotrexate for surgical management. 2 days after, there is rupture ectopic. So always the medical management is to be done in the IPD, in the hospital, because always there is, whatever may be the beta-hCG level, always there is a risk of rupture. So while you are doing medical management, patient must be admitted. Mass should be less than 3.5 centimeter. But among these two, this beta-hCG is more important than the mass. Hemodynamically, of course, stable, and mentioned already that list collection in the pouch of Douglas. So, and methotrexate, it is 50 milligram per square meter of body surface area. Then the beta-hCG is to be done, whether it is falling or not, by 7 days. If it does not fall, again you have to repeat the injection till it comes to less than 15% of the beta-hCG. So in that case, so 15% of that is percent, or less than 1,000 or like that. So then only we can watch for further monitoring by the beta-hCG estimation. Falling, there should be falling beta-hCG. So estimation of serum hCG weekly. So it is not the weekly. How is the missing of W? So up to 20 international units per ml, and there is always risk of rupture, as I have already mentioned. So this is inpatient treatment. treatment should be done in the hospital. That is about the medical treatment. Then it is expectant. Expectant is must be hemodynamically stable. Beta-hCG should be less than 1000. So this is very important, estimation of beta-hCG in ectopic pregnancy for planning of treatment, and no correction in the POD. In that case, you can assume that possibly the conceptus is dead, gradually it will be degenerated and beta-hCG is so falling, and after whenever it reaches below 100 or like that, you can discharge the patient. So that is about the expectant management. Then abdominal pregnancy is very important about the ectopic pregnancy. So usually the live fetus implanted following tubal abortion or tubal rupture. So that is called secondary abdominal pregnancy. So this should be secondary abdominal pregnancy, secondary to tubal abortion rupture. Placenta gets attached to the vital organ, even maybe with the liver. So a presentation is usually fetus is dead, but rarely it may reach the term. But presentation is repeated pain, recurrent pain abdomen. In a case of pregnancy, recurrent pain abdomen is the feature because the fetus is growing outside the uterus, within the abdomen. Means intestine, omentum, everything is stressed by the growing fetus. So recurrent and irritating the intestine. So recurrent pain abdomen is the feature. And intrauterine death will be intrauterine death with repeated failed induction. Suppose patient is a IUD, so you give misoprostol or you give some oxytocin, but there is no action. That means maybe you are dealing with the secondary abdominal pregnancy, because there is no place for expansion, there is no passage for expulsion. So that is repeated failed induction. Malpresentation. So whenever is malpresentation, that may be a secondary abdominal pregnancy. The presenting part is very high, so because it is freely floating within the abdomen, so it may go to the liver. So that is the malpresentation, and rarely may reach term laparotomy as soon as detected. Because any time that placenta may be separated, giving rise to shock and death of the fetus. So if you diagnose abdominal pregnancy, we should not wait for the pregnancy to become mature. Even if it is dead, by any time this placenta may be separated, patient may be in shock. So that is the rarely may reach the placenta removal. This is very important. While you are doing laparotomy as soon as detected, during laparotomy patient may die. If unknowingly, if you pull the umbilical cord, so placenta will be detached, and very vascular area placenta is attached, maybe with the vital organs. So bleeding will be so much brisk that the patient will die in OT. So operative shock, placenta removal. So usually placenta we leave the placenta as such and tie your umbilical cord. Gradually it will be absorbed. By risk is infection. Methotrexate may be given for quick absorption of the chorionic tissue, but always with this thing the risk of infection will be there. So usually diagnosed by USG, lack of uterine outline around the fetus. So sonographer, if he is not careful, may miss the secondary abdominal pregnancy. So he or she has to look for the uterine outline, not only the fetus. So that uterine outline is missing, and uterus is seen separate from the uterus. If it is found, that means we are dealing with the ectopic pregnancy. And superimposition of fetal shadow on maternal spine. Usually because it is separated by the uterus, so this doesn't happen. But if does happen in any of the images, so that indicates the secondary. Then come to the scar pregnancy. Pregnancy at the site of caesarean scar at lower segment. Myometrium is deficient at the scar. So either the sac will protrude towards the bladder or towards the peritoneal cavity, or towards the bladder rather, because lower segment is covered by the bladder, and or towards the uterine cavity, but presentation is with the bleeding per vagina and with the pain abdomen and like the rupture of the scar. So just like ectopic pregnancy presentation, detected by ultrasonography, fetal sac over the scar, fetal sac over the scar. So excision of the scar, removal of the gestational sac, and repair of the uterine wall. That is the treatment. But if it is associated with much bleeding, so if the bleeding could not be stopped, then hysterectomy may be needed in case of cesarean section scar pregnancy. This is a new entity. And come to the heterotopic pregnancy, that is coexistent of intrauterine pregnancy with ectopic pregnancy. So both are there, intrauterine pregnancy and ectopic pregnancy. So previously USG revealed that it is intrauterine pregnancy, but later on patient presented with pain abdomen and bleeding PV, all these things. But on USG we find that there is another pregnancy in the adnexa. So it is likely the ectopic pregnancy. So though it is rare, but that may occur, and salpingectomy done. So in these cases, because it is ectopic pregnancy, you have to do the salpingectomy, but never methotrexate, because there is another pregnancy within the uterus. So methotrexate is not given, never given. So after salpingectomy, intrauterine pregnancy may be continued. So pregnancy could be continued. That is the heterotopic pregnancy. And summary is the cause of maternal death, and USG can exclude intrauterine pregnancy. So because there is no intrauterine pregnancy and pregnancy test is positive, so that lead you to think about the ectopic pregnancy. Laparotomy and blood transfusion is life-saving. So lot of ectopic will die if transfusion backup is not there. You are in the OT, you have done. It was said in our days that no patient should die without laparotomy in case of ectopic pregnancy. One you have diagnosed is, if you don't do the operation, if you wait for the blood to come, patient will go down and patient will die. So you have to go to the laparotomy with the other replacement blood like the volume expander, and at the same time you have to ask the transfusion blood bank to supply the blood quickly. In two conditions we should not wait for the blood. Number one is ectopic, you have to go for laparotomy, otherwise patient will die. And number two is ruptured uterus. You should not wait for the blood. Even if the patient die, they should die in OT, but not leaving the patient for the blood to come and dying without doing anything. So that is a sort of counseling. You have to take the risk, you have to convince the patient. So to my experience, lot of things happen like that, and laparoscopy is very important for both diagnosis and treatment, that is the summary. One story I can tell you about the ectopic pregnancy. Last 2 weeks back, one pregnancy came with the bleeding PV and all those things, and possibly she had been given mifepristone and misoprostol for abortion. So usually before giving mifepristone and misoprostol, we do not locate the pregnancy. We assume that this is an intrauterine pregnancy, 7 weeks, 6 weeks like that. We prescribe the drug, but after giving the drug, patient goes into shock, and patient was admitted here. So immediately we suspected ectopic, and so we sent for USG. USG revealed possibly there is a sac attached to the ovary. So likely that was ovarian pregnancy, and then laparotomy was done and patient was saved. So that is also a presentation, and that is a risk of giving medical termination of drugs for medical termination by medical methods without counseling. So you have to counsel the mother, where you are giving the medical methods for termination of pregnancy, that there may be ectopic. So immediately, if you find anything, you find any dizziness of the head or any sort of things abnormal, any acute pain abdomen, you must come immediately to the hospital, because that may be a case of ectopic pregnancy. So if you want to be sure, you have to do an USG to locate the pregnancy, then you give the things. So that is all about our ectopic.